All right, well, funny story. This happened last week. A patient called up my clinical office and I said, I'm looking for an appointment with Dr. Ashley. That's me. And one of the nurses in my office would say, well, when are you looking for it? He said, I'm looking for it, in the next few weeks if you can. And my nurse said, well, unfortunately, the next appointment with Dr. Ashley, the next available is in 6 months' time. And he said, oh, I'm sorry about that. And then he followed that up by saying, could I get an appointment with Dr. Ashley's AI? This is a true story. And she was a little confused, and she said she thought she'd misheard him. And he said, Dr. Ashley's AI. He said, yep, I heard Dr. Ashley talk on a podcast, and he said he was turning himself into an AI, and that he was fine-tuning a model based on all the information that he'd written and the letters he'd written over a decade of practice. And I thought that maybe his AI would be more available than he would. Maybe this is the future. It's really my pleasure to be here today and join, and thanks for the kind introduction from Lloyd and for their leadership from Lloyd and Feifei and everyone else in bringing us together here to discuss this really important topic. It's my pleasure and privilege to moderate a panel of 3 esteemed colleagues, and I'm going to ask them to introduce themselves. And after they do, I'm just going to ask, just to kick us off, if yesterday was, or the story from last week was a moment of many that I've experienced where I realized the world was changing or had changed, maybe you could give us just one example from your life in any way that relates to AI where you realized that the world had changed. So maybe we'll start, Michael, with you. Start with your introduction.
I'm Michael Howell. I'm a pulmonary and critical care doc. Work at Google, where I've been for about 7 years. I'm the chief clinical officer for the company. Sounds fake every time I say it. And for about 20 years, took care of sick people, ran parts of health systems, and am a healthcare delivery scientist.
And have an example of how the world has changed.
Oh, mine is from the AI 2.0 era. So my undergraduate work was in Asian studies, but I was always very bad at it. And the ability to do visual translation where you can aim at, my focus was Chinese, where you can aim at things and then see it change. I was like, oh, the world is about to step over something that is new with that.
Great.
Hi, I'm Mildred Cho. I'm at the Stanford Center for Biomedical Ethics and in the departments of medicine and pediatrics here at Stanford. And I would say that, I'm not sure if I can top your story, but spending a lot of time on Zoom during COVID and also during the introduction of large language models, I realized during those Zoom meetings what people were doing while they were supposedly being on the meeting, and one of them was to write their own obituary. So I think people are going to be very creative about how they use new technologies in ways that I would never anticipate.
From editing Wikipedia, so Lisa.
Hi, everybody. My name is Lisa Lehmann, and I'm a primary care physician with a background in philosophy, moral philosophy, as well as health services research, currently on the faculty at Harvard Medical School and Harvard School of Public Health, and most recently the director of Bioethics and Trust at Google, and a former chief medical officer for Vision One for the VA New England healthcare system. In terms of thinking about how AI has changed the work that I do or life, I think as a bioethicist over the past several decades, been very focused on clinical care and helping patients and families and clinicians infuse ethics into healthcare, and the focus of AI in terms of the tremendous opportunities that AI brings to us in terms of improving patient outcomes, it has completely changed in terms of my focus on AI ethics and thinking really about what does responsible AI mean in the context of healthcare, and how can we implement AI ethically and responsibly and monitor that in an ongoing way. And really have had a privilege of working with the Coalition for Health AI. It's great to see Brian Anderson, the chief of the Coalition for Health AI here, and their work that's very focused on the responsible implementation of AI.
Yeah, I think it's a particularly interesting moment because, not unlike the pandemic, this is a moment that really touches almost everybody. There's a lot of hype cycles in medicine and technology that touch a small group of people who are very interested, but this is something really that is touching all of us. And obviously our focus today is health, and I can't think of a more qualified panel to talk about that. So let's move on. We get to start with raise. So we're going to start with the letter R today. And R stands for responsible, because I think that we all have a sense of the huge power of this technology to really improve lives if deployed well and in the right way. But that latter part is really what we want to focus on, I think, here in our panel. Maybe just we could start with you, Lisa, at the end. Thinking about that word responsible and the sort of frameworks that we might need to set up, knowing the power of the technology that's here and how it could really change. How do we make sure that we're changing for the better and that we do it at the right rate and looking after everyone in society?
Wonderful. So I think this is such an important question, and it's really the foundation of where we begin. We certainly have a lot of principles, and we have ethical principles in bioethics that are very focused on clinicians' professional ethics. We also have public health ethics principles that I think may guide us even more in this space as we think about the translation into the healthcare world. I think the first, and there are clearly frameworks and principles out there for responsible AI. The challenge, in my opinion, is that they're too high level, right? When we talk about trustworthy AI, well, what does that really mean? We have this idea of safety or of equity, health equity. What are the ways in which we are going to measure fairness in AI? Can we achieve some kind of consensus in the healthcare community about how to do that, and with an understanding of what those trade-offs might be in terms of different conceptions of fairness? So I think as we think about responsibility, the first step is governance, really. How do we implement a governance process in our healthcare systems that has the oversight for AI systems throughout the entire life cycle of an AI, from the development process through to the piloting and the deployment with an ongoing monitoring? So maybe I'll pause there.
Yeah.
But that's
but I wonder, Mildred, if you wanted to pick up on that. Governance obviously critical, but at what level should that governance be? Or, do we need it at every level? Maybe do you want to start, Mildred, and take it from there?
Yeah, I think that's a really important question, because I think one of the challenges of AI is that it's a technology that is incredibly diffused. The people who do data work at all different levels, all the way back to collecting the data, annotating the data, all the way through developing models and implementing those models, that is such a diffuse landscape, and there's responsibility that's also diffused. And so it's very easy to say, well, that's not my problem, that's for somebody else to handle, right? And so I think that's why you need governance at many different stages, but it also has to be coordinated so that there's nothing that falls through the gaps.
And we've obviously seen some leadership from some governments in this area, and some guidelines, some of them quite specific, even down to sizes of models, and that goes out of date obviously very quickly. We're also dealing with a system where we have a complicated healthcare system, and we also have industries. We have technology that, in many ways, the compute available in order to develop some of these technologies, of course, only available to a relatively small number of tech companies that have the sorts of finances that allow them to gather the chips that allow them to do that training. What do you think, Michael, in terms of governance across that, let's say, healthcare system and industry kind of divide?
Yeah, thank you for the easy question.
I like to give you the easy ones.
It is, just to sort of say it out loud, that's a question that needs, 6 hours to have a conversation, which is part of what today is about. But I'll start the conversation. We have a document called 10 Things We Know to Be True. And the first thing on that list is focus on the user, and all else will follow. And that lines up remarkably well with the principles of biomedical ethics. But there are two subtleties to it about who the user is and who you're talking about. So you give this great example of a patient who lives in the right geography, but can't have access to you in a timely fashion because you're constrained by the amount of time that exists. My family's all from kind of scattered across backwoods Alabama. They also don't have access. If we lensed out for a second and I asked this room, what's the leading cause of death among people ages 5 to 29? The answer is traffic accidents. Enough that the United Nations set in its Sustainable Development Goals a specific target of reducing traffic accidents by 50%. 92% of those deaths are not in the United States. And so, first, health is more than healthcare. And thinking about who the user is really important. The second is that these models are dropped into a complex adaptive system in two ways. One is that the technical system that they run in is a complex adaptive system. But the second is that healthcare itself is a complex adaptive system. So if we lens back to the US, the modern healthcare system, just from a math perspective, has complexity similar to that of a living organism. And you see things like if I took my profession in the ICU, for people who are on mechanical ventilation from ARDS, if a nurse, a doctor, and a respiratory therapist, maybe a pharmacist, round together versus round separately, and you're in the ICU on a ventilator, your chance of dying is a third less for that. And so these models and these tools are entering a complex adaptive system, and it's important to think about them in that way. And Ron Lee and Nigam Shah here have written about a bunch of things like that.
Just before we move on to the next question, I just want to mention we'll chat a little bit here among ourselves, and then we will take questions from the room. We also can take questions online, and you can, even if you're in the room, put a question online by going to the website and just typing it in. So we'll get to that in a few more minutes. But yeah, just to dig a little deeper on this issue, I think the need for governance really important. Sounds like multi-level and nuanced. But what framework do we need to put around that, I think is the question. Maybe Lisa, you could jump back in there. What does it really look like?
Sure. So I think Michael's point about who's the user is important, in that if we focus on that, then everything else will follow. I think in healthcare, as we're thinking about that, it's putting patients at the center of everything that we do. And so in order to ensure that AI it benefits our patients, we need to be thinking about their needs and their priorities. And I think that has several implications. One is, first of all, thinking about safety, right? And as we're thinking about implementing an AI solution, understanding, well, what's the purpose of this? Is the purpose to improve patients' outcomes at the end of the day, or is this just a shiny new tool that sounds exciting but may not have the real benefits for patients? Is this what patients want? So how can we develop systems and structures that are inclusive to make sure that all stakeholders are at the table and have a voice so that we can achieve patients' goals? So I think that's a beginning starting point, but really taking a step back and being rigorous in how we think about and evaluate AI systems, first and foremost from the perspective of patients and the healthcare system and safety.
How do we solve this question that that these systems are basically available to everybody? I mean, we can think about our lens from the the perspective of the healthcare system and think about governance here and what we want to do, and we can be inclusive in bringing patients to the table. They can also just sit at home and type their questions into ChatGPT. Should there be some framework around the health implications of that?
So personally, as an ethicist, I think that kind of patient empowerment is wonderful.
Yeah.
And it precisely because of some of the challenges that we've mentioned in terms of access to care, and the story that you shared, right, of the fact that we can't, as healthcare providers, be there for patients all the time. Wouldn't it be amazing if there was some way for patients to access healthcare 24/7 with their questions? Now, the flip side of that is, how do we make sure that the information that they're accessing is accurate, is reliable? That goes to the safety question. And that's where the due diligence, the responsibility comes in on the part of the people who are developing these systems and the people that are implementing these systems.
Yeah, I mean, I think you make a wonderful point. I mean, I really believe scaling empathy, because not everyone has access to empathy, and scaling that in a way that is responsible is one of the greatest opportunities, I think, of this moment. Mildred, say a little bit more about what framework you would like to see around both these two. I guess we're responsible for sure, but the safety element too. I'm interested if you have ideas as to how we can keep people safe, both the ones who are in our healthcare systems accessing AIs that are presumably somewhat regulated, and the ones that are not specifically regulated for health out in the world.
Yeah, I used to think that sort of the what we needed in thinking about how to have responsible AI was to kind of impose a medical model, a medical ethical model, where the center of that is professionalism, the best interests of the patient are centered. But I think that there are limitations of that we've talked about, which is that they tend to be very individually focused, right? It's like doctor-patient relationships, and that it's too narrow, and yet in computer science and data science, the professionalism ethics is really focused on competence, right? Performance and accuracy and being a good, scientist or developer. But it occurred to me that those are 2 of 3 of the pillars of trust. So competence is one, beneficence is another, but the thing that's not there is this idea of being able to demonstrate that you have shared values. And that's where I think the empathy comes in. And that empathy needs to be explored and interrogated over the widest range of stakeholders that are involved.
Yeah, that's great. I wonder if maybe we should move and take a question from the floor. If anyone has a question, I think maybe just raise your hand and we'll send a microphone to you. Or if there are also questions online. Otherwise, we have lots of topics we can continue to. Yeah, we have a question right here. The microphone is coming to you.
Back when Google started to organize all the world's data, you had situations where patients would review that information, and even to this day, come in having done extensive research, especially in this area, on their condition, and then talk to their physicians, and be actually far more educated, perhaps, in certain areas, and maybe in certain areas that the physicians weren't so keen on them being educated on. So are there data points that you could extrapolate from that experience that would allow you to basically say that, hey, this was our experience back in the day with the use of search engines and the proliferation of information, and how does that actually go next level now with AI?
I think that's one for you, Michael.
I guess I'll start. There's this tension. So I, for 14 years, was at the Beth Israel Deaconess, which is the first place that implemented open notes. And if you want to see a bunch of intensive care docs get kind of like sweaty and nervous and pupils dilate, you talk about open notes. And now they would never go back for it. So I'll share my favorite statistic. So I get asked, all the time, why is Google in health? And the simple answer is we don't have a choice, because hundreds of millions of people come every day and ask questions about their health pre-generative AI. I'll tell you my favorite statistic that I've learned since I came to Google, and it echoes, Mildred, the point that you had at the beginning. We would never imagine what people will use these things for. So here's my statistic. 15% of what gets typed into the search box will never in human history have been typed in before. It's also true for health. And so we've worked very hard to do 2 things related to that. One is to have good ranking mechanisms to give high quality, authoritative information at the top. Really difficult when 15% has never been typed in before. And then the second is to have a framework, which was developed by the National Academy of Medicine and validated by the WHO, about identifying authoritative and credible sources of health information. And so you'll see those on, search and YouTube in a prioritized way. As we move into the generative AI era, I think that there are lessons from that, but that the context is also quite different. And so we spend a bunch of effort, which we've published most of, on how do we evaluate these models, which requires new capability development in terms of measurement, as well as in the technical development of the models themselves.
Go ahead.
So I'll just
Yeah, good.
Does this sound? Just to add to what Michael said, one of the principles here that I think that we can learn and should focus on is transparency. Because in order to get to a point where we have confidence that our patients are accessing high quality information, right? That was the challenge with people going to Dr. Google, right? Were the search rankings putting the authoritative content high enough up? When we move into the generative AI movement and model of patients interacting with generative AI to answer their questions, if we don't have transparency about the data that is being used to generate those responses and a confidence that the quality of that data is excellent and aligned with our evidence-based healthcare data and understanding and values, that's where we get into challenges. And so I think we still have a long way to go in terms of large language models and generative AI in terms of understanding the content and the data that goes into it to have that kind of confidence for the medical world. And that's why I think we're seeing the advent of generative AI systems that are specific to healthcare with the hope that they actually include evidence-based data and data that is going to be high quality so that we can get beyond our patients accessing information that is not good health information.
Yeah, really important point. Mildred, I wonder if you want to take one of the first questions here that we got from the online audience, although of course may have been from someone in the room accessing online, but is the panel aware, maybe you can start, of any efforts to integrate ethics into the AI model development itself? So not thinking about it post hoc, but starting from the beginning in thinking about building a model that has ethics kind of built in. I think that's the question.
Well, I think that there's a lot of work being done to take ethical principles like fairness and justice and that sort of thing and sort of algorithmize them, turn them into, math, which I think is great. But I think that needs to be augmented by understanding what patients especially, but other stakeholders think fairness means. Because there's many ways you can turn fairness into an algorithm that all have different design trade-offs and outcome trade-offs. And so understanding what patients and caregivers and others in this ecosystem think about what counts as a benefit, what does equity mean, what is fairness, and integrating that into the modeling is a way to augment that.
And it sounds like what you're describing is kind of almost like a logic system, like an if-then sort of system that people have been using in algorithms. Are you aware of others that have tried to, you could think about, could you take an ethics textbook and, have the model train on that? Is that helpful? Are you going to get an ethical AI just by training on a series of words that happen to be describing ethical approaches to healthcare, for example?
Well, I imagine people are trying to do that. But yeah. I think, again, the problem with that is in ethics, you sort of always end up with a series of trade-offs or balancing. Mm-hmm. And so the final step in that has to be determined by, things that are external to the system. So you always have to get other information in order to make that decision.
Yeah, I don't know the answer to this, but what do the models say if you ask them the trolley problem question? Do they have a variety of answers? Do they answer at all?
I don't know, and I'm not sure I want to know.
Yeah,
I think maybe you just have to look outside and look at the self-driving cars to see if they figured that out.
Good point. Lisa? Yeah.
So I don't know the answer to that because I haven't tried to put the trolley problem into any of the generative AI models, but we have been in the process of studying with actually someone who is an employee at Google, also working on a master's in bioethics at Harvard, a series of bioethics cases put into generative AI systems, comparing that with actually how bioethicists would respond to them. And maybe not so surprisingly, they're actually really good in terms of the responses and their analysis of the ethical issues. Does that mean that at the end of the day, you still need the human to put it all together, to synthesize it, and balance everything out, as Mildred said? But it's pretty amazing in terms of how good they are.
Yeah. Any other questions from the room? Yep. Just at the back.
Morning, my name is Jessica. Thank you all for being here. My question is around liability and medical error. If something happens, who is ultimately responsible? Is it the physician, the engineer, the manufacturer, and what your thoughts are around that?
Yeah, great question. Another easy one for you, Michael.
Could I ask because I was actually going to ask the same question. So could
yeah,
I just ask
it's a twofer.
one additional point, which is, does this change the standard of care for doctors? So if a doctor doesn't consult an AI and misdiagnoses something, if they have a conflict between the AI and their own medical judgment, how are ethics and the system going to sort the standard of care that is now expected for a doctor? Thanks.
All right. A series of difficult questions. Maybe, Michael, do you want to start? And then we'll go to
No,
Mildred.
thank you.
Yeah, right. Okay. Short answer. Good question.
It's first, I think we think AI is too important to not regulate and regulate well, and we're seeing a number of positive moves in that regard. I think that, as Feifei said, it is a multi-sectoral piece of technology, and so it's really important that, if you have a patient who comes to Stanford, where they also may go to CVS or Walgreens or Target or Rite Aid, and that the way that AI is regulated can't vary fully between health and retail, because what do you do when they go in there? And in practice, they go in there a lot. The second piece is that I think that there is something to learn in the history of medicine here, where there was a time when the curriculum for medical students did not involve laboratory medicine. You didn't need to know what a creatinine was because you couldn't get it. And then it showed up. There was a time when knowing how to run a spreadsheet wasn't part of the accountancy curriculum or CPA exams. Accountants didn't go away, but they became responsible for overseeing it. So we think that AI is not going to replace doctors, but that doctors that use AI will replace those that don't, in the same way that doctors that use laboratory medicine replace those that don't.
Yeah. And certainly before there was good search engines and reliable health information, we had a similar question and concern about if a patient or a doctor looks up Google and makes a choice that is different from the one they'd otherwise, who would be liable for that? It's probably not different from that scenario.
Or even before that, like anybody old enough here to have used Index Medicus, where you actually went to the library and like schlepped out the book
Those
and
were the days.
looked for the thing. Like, I think like access to information is better now than it was then.
Yeah, this is better. Mildred.
Well, I just wanted to say that we have the world's expert on liability and AI sitting right there, Michelle Mello. So if somebody could give her a microphone, I'm sure she could answer that question very comprehensively.
Shall we do that? Is she willing?
Sorry to put you on the spot,
Yeah.
Michelle.
And thanks for coming, but you're now being put to work.
I'll answer just to commandeer the mic to ask a question next. But I think the answer is that there's not really anything new about this problem, in the sense that the legal standard of care has historically evolved to accommodate the incorporation of new technologies into clinical practice, and the point at which that becomes customary is the point at which it becomes legally required. We're not there yet, so there's a lot of uncertainty, as I've written about. But to my question, I wonder if I could get you to tell us a little bit about what you see as fair and reasonable to require of developers of foundation models. Unlike narrower predictive models, the task that they're built to be good at is not the same as the task that I might use them for or you might use them for. And so how should we be thinking about responsibility for the performance of those models? And is your answer different depending on the extent to which the developer is seeking to monetize the model?
Great question. That's what you get for like pitching a question to the audience. Mildred, do
All
you
right,
want
I'll
to start?
throw myself on my sword here. Well, so I think that it's very Wild West with these. There's no evaluation at all. So in some ways, the bar is very low, even though it is a tough problem to ask. And because there's all these different uses, it's very hard to evaluate and understand how to evaluate. But I think any attempts at evaluation would be of help in terms of at least potential harms and harmful uses that could be predicted. In terms of your last question about who's developing it and is my answer different, I would say I think in my blue sky case, yes, it would be different. I think there should be a high bar for any technology that's being developed where there is this financial conflict of interest. And we sort of have that as a default in regulation of medical drugs and devices, but we don't have that for AI. So I think, yes.
And Lisa, do you want to deal with this question? I mean, I think the essence is the breadth of what a foundation model represents. Maybe if you could say a little more on that, and then we're going to try and squeeze in one more question before we finish.
Sure. So, Michelle, it's a fantastic question and clearly a really difficult question. I'm inclined to think that if a developer is monetizing the model, then there is a onus on them to demonstrate that it is safe and effective in the context in which they're trying to monetize it, right? So that developer has that responsibility. In many ways, that requires partnerships and collaboration, I think. And so if we think about healthcare, for example, and the desire to integrate and implement large language models in that context, before we just kind of put them out there and deploy them in, like the Wild West, right? We as healthcare systems providers have that obligation to ask the tough questions of the developers and to also, I think, work collaboratively to try and demonstrate or rigorously study the models to try and anticipate potential harms, to mitigate those harms and before we actually deploy them. So it's a difficult question, and I think that the ability to understand what responsibility means for these models, I think, is partially dependent on the local context in which they're deployed in, right? So we have to have those kinds of partnerships in order to be able to actually evaluate and assess them.
Well, we just have a couple of minutes left, so I'm going to ask for each of you to make one comment on this last question, which is really just so much of what we're talking about here is future-looking and futurism and thinking about what the future is and making sure we walk that path in as responsible a way as possible. The world seems to change every day. Many of us probably watched the videos from GPT-4o last night and watched another generation of these models like leap forward again. Where do you think we'll be in a year's time? And from obviously a responsible and safety and ethics perspective, but where a year is a long time. A year is a decade in the current world. Can you take us forward there and see if we were at this meeting next year? What do you think we'll be talking? Will we have solved some of these questions? Will my AI be seeing 100 patients a day? Give me a sense of where you think we'll be. Michael, why don't you start?
It's very hard to predict your way out of an exponential, right? So I think, with that caveat, I think 2023 was the year of like, ooh, look, shiny. And 2024 is the year where in healthcare, generative AI is meeting the real world. And you learn a lot as things meet the real world. And so I'm hopeful that this time next year, there will be people with real examples of real help to patients, help to providers, help to health systems and payers and life sciences companies that are more than early prototypes. And I think that we will have, in terms of evaluating these things, to Michelle's point, we're 1 minute into a 90-minute match. And I'm terrified every day that someone's going to come and go, good news, we figured out how to make it smell, and we want to use it in healthcare. Can you help us evaluate it? I think we'll have some, that the measurement will have matured a little bit this time next year, but we're just 1 minute into a 90-minute match.
Perfect. Mildred?
Well, I'm going to punt on the prediction and just go with the hope.
Oh, see, that's okay.
And say that I hope that we will figure out a way to really include other stakeholder voices from the very beginning.
Yeah, love it. And Lisa?
So I think healthcare systems are still recovering from COVID a little bit, and they haven't been able to invest as much in AI. And I think in a year from now, we're going to see many, many more healthcare systems that actually have developed a strategy, have thought through the governance issues, and are really primed to implement AI in a careful, thoughtful, and responsible way.
Perfect note to end. Please join me in thanking the panel.